I'm Talha Badar, hematologist at Mayo Clinic, and we'll be discussing our study on U2af1 mutation in myeloid neoplasms. So U2af1 historically was considered an intermediate risk marker until 2022 when European Leukemia Network classified this group of patients to adverse risk phenotype because of the historical data we have. And U2af1 is one of the splicing factor mutation. And in our previous studies, we have found heterogeneity in the outcome of patients with different amino acid sequence in myelofibrosis. And so we try to learn how is it different in a patient's MDS AML in contrast to patients with myelofibrosis. Historically, there is some data on showing the heterogeneity between two most common variants which are observed in patient myeloid neoplasm, including S34F and Q157P, with one being adverse risk phenotype compared to the other one, and is more prevalent in patient myelofibrosis, such as Q157P compared to S34F. So we try to learn how is it different or similar compared to myelofibrosis. So that was the rationale. And we have a big data set around 179 patients with comprehensive genomic sequencing and molecular annotation. So we find this opportunity to elaborate and analyze these patients, how they behave and respond to therapies, how they're unique in terms of their clinical characteristics, and how is their outcome, in order to learn how to manage these patients. One of the contrasting features in an analysis compared to myelofibrosis, in which amino acid sequence U2F variant Q137P is found to be more prevalent compared to S34F. We found that S34F was more prevalent in MDS and AML compared to Q137P. That was the one contrasting feature we found difference among patient myelofibrosis compared to MDS and AML. The second feature we found that there's a differential co-mutation clustering between these two common pheno variants, right? S34F, which was more prevalent in 60% of this cohort, are more aligned with B-core mutation, which is another adverse risk mutation. And this is mutually exclusive to other splicing factor mutation like SF3B1, SRSF2, and ZRSF2. That was one. The other thing we found that Q137P cluster more significantly with P53 in AXL1 mutation and is less prevalent compared to S34F. That was among the characteristics, the molecular characteristics we found. The second thing we found in patients who had a pre-cancerous condition like or pre-myeloid neoplasm like CCUS, clonal cytopenia for interim significance, the incidence of this mutation was higher, and there was a short latency of CCUS transforming to advanced myeloid neoplasm, such as MDS and AML. The third thing we observed in terms of treatment, there is some data from other groups from our leukemia community showing that venetoclax-based therapy abrogates the adverse risk phenotype of the splicing factor mutation, either combined with low-intensity chemotherapy or high-intensity chemotherapy, saying that it nullifies the adverse risk phenotype when you treat these patients with venetoclax-based combination. In our analysis, although the proportion of patients who receive venetoclax-based therapy with HMA mainly was small, but we didn't find any contrasting difference in terms of response rate compared to hypomethylic agent therapy alone or intensive chemotherapy. With some acknowledgement, this is a retrospective analysis, and that was not our focus of attention in this, and which was the main hypothesis to be concluded. Third thing we observed that Q137 mutation had a significantly adverse outcome compared to S34F, as we have seen that these patients were clustered with P53 mutation and other AXL1 high-risk mutation. These patients tends to have a dismal outcome in overall cohort in high-risk patients, seeing survival close to 1 year compared to 2.5 years with other mutation in patients with high-risk MDS/AML. High-risk MDS/AML are those patients who had myeloid blast 10% or more. The second observation in multivariate analysis, we observe that the only factor that tends to improve long-term outcome and attain favorable significance in terms of treatment is allogeneic stem cell transplant. And to limit the bias of the retrospective analysis, we did a landmark analysis from the time to achievement response and see how they differ in terms of long-term outcome. The bone marrow allogeneic stem cell transplant retains significant improvement in long-term outcome. So with this, we conclude that U2af mutation, which is an adverse risk phenotype, had a heterogeneity in terms of their molecular profile and outcome. Second thing, we observe that patient with CCUS, they tends to have a short latency in progression to advanced risk myeloid neoplasm. Third, we observe that S34F tends to have a favorable outcome compared to other high-risk variants such as Q57P, which was the second most common amino acid sequence observed. Fourth, we observe that bone marrow transplant can abrogate the adverse risk phenotype associated with this mutation. And although the current classification system, which is the ELN 2022, only uses the mutation, not their allelic burden or variance in terms of prognosticating. But in future updated risk stratification tool, we should also focus not only on the mutation, but also their allelic burden, as well as amino sequences that have a meaningful impact in determining outcome of these patients. And moreover, since we are seeing more splicing factor targeting therapies are being evaluated in clinical trials, this needs to be considered in the analysis and accrual of these patients. The other observation in previous studies have found that these two most common variants of U2af mutation, S34F and Q57P, is more correlated with anemia and thrombocytopenia. However, in our analysis, we didn't see any significance in terms of anemia, thrombocytopenia, or transfusion needs between these two commonly occurring variants, which have been observed previously.